translating science into clinical practice. At this time, we will have public comment. Just a reminder on the public comments today, the guests are allowed to speak for 3 minutes maximum on an agenda item that is scheduled for approval. So if we can check to see at this time if we have public comment.
Dr. Nichols signed up, but she did not put her topic of discussion.
Okay. Dr. Nichols, you're recognized. If you'll go to the podium. We don't have your topic of discussion, but you can go to the podium.
Well, no, I just signed in just in case I need to bring the public comment.
Oh, okay. All right, good, good.
No comment.
All right, good. Thank you, Dr. Nichols.
Right, if necessary, for questions addressed.
All right.
But I have no comments.
Thank you. You all have been given a copy of the minutes and had a chance to review them. If there's any additions or corrections, we're entertaining that now. If not, we'll entertain a motion to adopt them. Move approval. Been moved. Can I get a second? Moved and proper second. All in favor, vote by the sign of aye. All opposed? Ayes have it. Our minutes are adopted. We're now on, old business, hospital utilization. Ms. Poole, you recognize?
Before we move on,
Yes,
I just
absolutely.
have a quick question.
Uh-huh.
Regarding old business.
Turn your mic on.
Oh, sorry. My bad. Just old business and how we wanted to address some of the action items. So thank you for putting this in the minutes as requested from last time. So I think that was one of the things we were going to change is making sure that we address those and had a follow-up. Thank you.
Duly noted. Ms. Kathy?
Conflict? Or do we want to? Sorry. So the action items, as I saw it, were conflict of interest documents. So I don't know where that stands. Discussion of exit interviews and the update on NGH and Meharry. I had a couple other things added that I can work with Janet on. But how, Mr. Chair, do you feel like we should address these? Because, again, I just don't want them to continue to be an action item and move forward without some discussion about what that looks like. Thank you, sir.
So one of those items we will address in strategy session a little bit today. So we'll have an opportunity to deal with that. And then a couple of those other items, I'd really like to work with the executive team so we can get those completed, particularly around like the conflict of interest and some of those things. And so we can dig into that. Yeah. But we'll definitely have an opportunity for some healthy discussions later in the meeting on that other item.
That's fine. Thank you for that, and we'll look forward to seeing the conflict of interest document. Is that something we need to approach outside legal counsel for? Or is that something we do in-house? How did that been addressed?
Yeah, again, I think we ought to give it to our executive team and the legal to just kind of give us some direction on it. I don't want us to try to recreate that wheel during this meeting.
One question, Mr. Chairman. Does public comment make the minutes or not?
Have we?
We typically don't write it in detail. We just basically address the fact that so-and-so spoke and maybe a little of the topic. I think that's what I've been.
Did you hear that? So give me a chance to, let's get with legal, Chris, back to your question. Let's get with legal in terms of those parameters.
Yeah, I think so. Stacy is our general legal counsel for,
Yes.
Okay. So you can work with us on the conflict of interest statement. Thank you so much.
All right, so we're back onto hospital utilization. Is Kathy giving that report?
Good afternoon, everyone. For hospital utilization, it's typically specific to the Metro Employee Incentive Program. Since first quarter 2024, we've seen an 18% increase in Metro utilization. Quarter one, we were at 680, quarter two, 764, and this last quarter, we were at 802 as part of the Metro Healthcare Incentive Program. And then also, just one other KPI, if I can read all this tiny numbers, for our ambulatory volume, we brought on a couple of new providers. So from January to February, we actually saw double the number. We went from 1596 to 3765 in just 1 month. And the third month we were at 3802. So moving in the right direction.
Quick question.
Yes.
Congratulations. I know you've been working very hard at this and it feels like for quite a while. Are you all tracking like what is responsible for that? I know you were maybe doing some mailers and you've gone on site to different places. Are you able to like quantify so you can continue those efforts and spend more time there?
Unfortunately, like with the Metro incentive, I can't quantify by department. So yes, we did do items with Metro Action Commission. So I would expect to see a little bit of jump just probably this month more so since it just occurred the previous month. So that's why I looked back at Q1 to actually Q3. And then we've really done most of our advertising right now. There's some radio ads out there about our emergency department. So we should have more data on that next month as well.
Yeah, that might be helpful if they fill out a questionnaire and just to get a better idea.
And we can see with our, we're doing a lot of point of service surveys. So also being able to track the surveys back to the appointments within the service lines. Okay, thank you.
Thank you. We will now, for the sake of time in this particular meeting, I know we have several contracts and some other things we're going to spend a little time on. I asked them if they would defer the marketing report until our next meeting, if that's okay. We'll get a update on that at our next board meeting. But I do want to hear our quality report. Dr. Hudson, Dr. Williams, you're recognized.
Sorry. Thank you, Mr. Chairman. I think we had planned for Dr. Hudson to attend our meeting, but she has a standing conflict. So, number one, the quality report is in your board report. I am available for any comment. I don't know, Dr. Hudson, if you wanted to try and find someone else to fill that role, or did you still want us to try and change that date to accommodate your schedule?
I know Janet had mentioned that you are maybe looking at another date and time.
Okay.
I'm happy to explore that as well. Or if that works, for the majority, that certainly you can find someone else from the board to sit.
If you're still interested, we'll try and accommodate your schedule. Okay. But the report is there for anyone's questions. I'm here.
So the quality report is in your packet, and this is something that we'll have to approve. So are there questions or comments relative to this report?
I guess, the dashboard looks good with the exception of a fall off in responsiveness to staff. Is there any known reason for that or efforts toward changing it?
I think in this particular instance, we had actually a traveler who we had to actually counsel around this area. So I think you're going to see better improvement on the next report. And, you know, we get so few responses that one bad response can really hurt you.
You think that's the same case with willingness to recommend, because there was a dip there also?
Yeah, I think that, you know, if you have a bad experience and you say, no, I'm not going to recommend the hospital, that really hurts you. I don't know if there's duplication here for these two, if it's the same patient or not, but we did have some issues with travelers in the last month.
Thank you.
So,
And just so the board knows, you know, when you get a traveler, they're not really invested in whatever your initiatives are unless they're naturally invested. But there are a lot of folks who say, look, I'm just here to do my shift. I'm not concerned about your, you know, your mechanisms for making patients feel comfortable, et cetera. And that's one of the challenges we had.
Has the new patient experience director expressed any plans to address patient-centered care and satisfaction and all that kind of stuff? Looks like someone just started. Is this something that they're actively looking into as well?
I can't address that at this point, and our CNO is out.
I can.
Oh, go ahead, Dr. Webb.
That's ongoing. That's a daily activity. Answer to your question. Yes.
All right, if there's no other questions or comments, I'll entertain a motion to adopt the quality report.
So moved.
second?
Thank you. Been moved and properly second. All in favor, vote by the sign of aye. All opposed? Ayes have it. Thank you, Dr. Williams. Let's see here. All right. I know the finance team was digging in, and I walked in and saw you all digging in on these contracts, so we're ready to review those for the full board.
All right.
Dr. Brown?
Again, good evening, Mr. Chair. The contract that I'm presenting today is Nalco Water. This contract is a 3-year contract, $32,953 per year. It's a 3-year. We did receive 3 bids, and we decided to go with this particular company to provide services that help us with the cleaning of instruments and Legionnaire's disease throughout the hospital, testing water that doesn't get used that often within the hospital here itself. So we're asking the board to approve this contract.
Thank you. Finance, can you give us?
Sure. We discussed this contract, and the Finance Committee unanimously approved and recommends it to the full board.
Thank you. Questions or comments on this particular contract? If not, I'll entertain a motion to adopt.
Second.
It's been moved by Mr. Lesser and properly second. I'm sorry. Okay. All in favor, vote by the sign of aye. All opposed? Ayes have it. Thank you, Dr. Brown. Mr. Nairmore, you recognized for the Space Labs contract.
Yeah, so apologize, Mr. Nairmore. We have, in Finance Committee, deferred this specific contract, so we would ask that you move to the next contract.
All right, thank you.
Thank you. This one is a contract. You guys understand that we're proceeding rapidly with the implementation of the Cerner Oracle EHR in the hospital here for both the hospital and our clinic platform. And in the original design, we started negotiating this 18, 20 months ago, and we whittled it down to 2 EHRs, and then we ended up selecting, and the board approved the Cerner contract, now Oracle. But at the time, we had the belief that we would be able to use the Cerner accounts receivable system and have Parallon, who is our third-party billing collection vendor, work inside the Cerner AR platform. Ultimately, well into the discussions, we learned that Parallon had a very bright line that they would not cross and work in somebody else's AR system because of the algorithms and the compliance issues that they have to deal with. So we had to sort of do a change at that point. And so we're going to have to interface from Cerner to Parallon and from CareCloud to Cerner, which is CareCloud is our clinic billing process. And in order for the charges and the payments and adjustments to interface back into our general ledger now, because we're not using the traditional Cerner platform, we have to have some interface work performed to tie those together. So it's not a really significant, but because it hits the $50,000 threshold, we needed to bring it to this board. It is a one-time spend for $50,000 to build out these 2 interfaces. It'll tie our general ledger back into the Cerner AR system through Parallon and CareCloud. So I don't want to get technical, but basically it allows the charges, payments, adjustments, cash posting, refunds to update my general ledgers so they're in concert together.
Finance?
Yes, thank you. We had a healthy discussion around this contract. We discussed the funds actually coming from the operational budget, it not being in scope at the beginning, but it being a one-time necessity with some potential small upgrades that wouldn't be costly. We also discussed the Cerner go live date of December 2024, and this being done within probably around 45 days after the Cerner go live. So hypothetically, it's eligible as well for the 4% money, but at this point, we'll go from operational budget. Thank you. And also unanimously approved by the Finance Committee.
Thank you. Any questions or comments on this particular contract? If not, I'll entertain a motion to move for approval.
So moved.
Been moved and properly second. Ready for the question? All in favor, vote by the sign of aye.
Aye.
All opposed? Ayes have it. Thank you.
Thank you.
All right, and our final contract?
Good afternoon. We're going to talk about the Oracle Health Population Healthcare Management Consulting contract. This is 10 years. There are some changes to what you see on the agenda regarding the one price for the professional services, so we're going to talk about that. I'm here with my colleagues and subject matter experts who have been working with Cerner for the last 18 months. Kalela Hatchett, who is the Senior Director of Population Health, and Brandy Plunkett, who is the Director of Clinical Informatics.
Hello. So the proposal that we're bringing up today would cover 4 platforms that we are adding to our Community Works EMR system. This was always a phase 2 project for the implementation of our new AHR. The 4 products that are entailed in this proposal are care management, chronic conditions management, social determinants of health, and also for our analytics team, our enterprise data warehouse. So we have engaged over the last year with our Cerner team to talk about the pros and cons to these modules and these platforms. And we've also considered other platforms that do similar work that we could have signed on with. What I will say is when we looked at other programs, platforms that would work with our Cerner platform, the main issue for me was that the information was unidirectional, meaning that the information would come out of our Cerner Community Works platform and go into the other platform, but not back into the original platform. for me, as I work in analytics, that poses an issue with, being able to pull data readily, having it readily available to our team, whether it's clinical, for quality. We also support finance, revenue cycle, all the other service departments within the hospital as well. Did you want to say something to this?
Yeah, so I would just say, as it relates to this product that sits on top of Cerner, this is supported by Cerner. It's the Cerner team that we will be working with throughout this implementation that is also supporting this. This is a product that is, conferences are held annually that we will be able to attend. We're at the table with Cerner discussing improvements within the product, the complications, if any was to arise, we will be working with the Cerner team to iron those out. That's not necessarily something, had we considered another product, that we would have been able at the table, because you would have two different vendors trying to work to resolve one issue. So that now that this sits on top of it, it provides that interoperability in which the whole point of choosing Cerner was for that interoperability and patient throughput, patient care, data research, and so forth.
I just wanted to also mention that my team also supports our care management program. And so the care management platform, the social determinants of health, and the chronic disease management all support that work that's being done. So we're working with our high-risk patients, working to educate them on how to, utilize lower cost services, how not to utilize the ED for, just a medication refill. What are those things for? We're also supporting them if they have food insecurity, if they have housing issues. These platforms can manage more than just our clinical data. It really helps us get a good picture of our patients. It's where my case managers would be able to document that information. So we are able to create goals for our patients, track the progress for our patients. It allows our team members to be able to toggle between our cases and be able to do that efficiently. For the EDW, that supports our analytics team. So what we are dealing with right now is we have two disparate systems. We have ECW, we have Paragon. And as we bring on Cerner, we would have a third. What the EDW will help us do is to bring all of that data together in one place. It allows us to be able to run reports more easily, be able to get that turnaround time a lot lower. There's also data visualization within the tool. So we have Tableau within the tool that will help us, and also it helps our end users that will all be there for them to be able to use at any time, and they're not waiting on our team to pull information every time. So what it allows us to do is we can maybe create that visualization for them, but then going forward, they can review that at any time, toggle between the dates of interest, look for tracking and trending on there as well. So what it'll do is just open up the access for data within our organization.
And then in closing, I think it's important to note, look at the harmony between these teams and all of the different units within the hospital, particularly our burgeoning research world that we're working in. And so if we want to be agile and facile and cutting edge in comparison to other hospital systems, to be able to work internally with our investigators and investigators from other research institutions that have these rapid queries for feasibility studies, for data pulls, and whether it be pharmaceutical studies or observational studies, these tools and their interoperability will allow us to do that. So it's many dimensions of the work that are being accomplished by these four modules. You've heard from informatics, you've heard from population healthcare management and revenue cycle, all of the different components of this, and then also our research program, which is expanding. So we're really future-proofing how effective and efficient we can be with all of these modules together on top of Cerner.
Thank you. Thank you for the details around that. Finance Chair.
Thank you. We discussed this contract at length. I know I personally struggled really just to understand it, not being from a healthcare world, but I know Dr. Martin and Dr. Hudson. Yes, I'm sorry. We discussed it. Yeah, I know, Dr. Hudson. We served on another committee together, so I don't know why I blanked. Sorry about that, friend. It's been a long week. But we discussed it this length, so I'd ask you to jump in here, but just to kind of summarize, I struggled with trying to understand, one, just the cost structure, and then also kind of, was that a, one time, we're amortizing that out over 18 months. So the actual, I guess, the build, the technology platform that we're buying, and then also concurrently the 10-year monthly ongoing costs. So, I think it's important as we are looking at these contracts to truly understand the full scope, which I completely support the goals of this, but to understand this is a $2.8 million contract. And so one of the questions that was brought to light was, is there an out? What would that look like? Is there any, downside? So if my two fellow friends and committee members would like to weigh in.
This is an absolutely essential program that's happening at other hospitals, and something that should pay for itself, but more importantly, be reflected in outcomes. And I think the board would look forward to, report in the future as this develops, and how that is being true. And one additional way is it brings revenue into the hospital for clinical trials, is my understanding. It's unusual to approve a 10-year contract. We did that, as pointed out in the previous meeting, with the EMR, with Cerner, and since this really is an add-on to Cerner, then it makes sense to approve it.
And colleagues have said everything, but the one point that I want to make that we talked about during the finance meeting is just that other hospitals have been able to utilize this data for their patient outcomes. And I think a better way of looking at it is that this hospital it's been a disservice not to have a vehicle like this. And so, yes, it's costly, and we had to kind of get a better understanding of what all this product can do, or these services can do. But I think we've been at a disservice, and this will kind of level the playing field and ultimately help our patients. So.
Am I correct in thinking that some of this data collection, including social determinants of health, is going to be required?
Yes. Yes.
So we really don't have a choice in not collecting this data, probably.
Yeah, no, that's definitely what we're trying to work towards now. We're doing prepare assessments to understand our social determinants of health for our patients. And we are also, when we're thinking about health equity and really just trying to support our patients, that's definitely something that we're working towards. And it's going to be required when we talk more about value-based programs.
Thank you. Thank you to the Finance Committee for really digging into this and spending some time on this. Just for clarity, I think I mentioned this once before. When you all type out the agendas and you're doing particular contracts, if there could be consistency, so the total should be the total amount of the contract in its entirety. So in one space, the total is that, and then the other space is not. So if we could just do that in terms of what we're approving for clarity. And I know we have we have the contracts, the full contracts, you've given those to us. But just in terms of what we are approving. So when you said 2.8 million, that's what I would have liked to have seen here. So if we could do that.
And our committee did unanimously vote to approve this and move it to full board. So thank you.
Thank you. Any other questions or comments? All right. Well, we'll entertain a motion for approval.
So moved.
Been moved and properly second. We're ready for the question. All in favor, vote by sign of aye. All opposed, ayes have it. Thank you. Thank you so much for your presentation. All right, we'll have our medical staff reports and our credential reports, and we'll ask Dr. Williams if he'll share that information with us.
Thank you, Mr. Chairman. First, the update on the bylaws. As the board is aware, the bylaws document was not approved. We brought that to the Medical Executive Committee to ask them what the next steps were going to be. And I'm trying to be thoughtful about giving some background to the board because I find that we assume that you know things that you don't. But the bylaws document that we were working from was a document that was produced by a local law firm here in town that's independent of this organization, but also the document they gave us to work with is a document that is already in play at several CHS hospitals, HCA, and LifePoint hospitals. So we try to use a document that's familiar and being used around the nation. The document did not pass, and so I asked the MEC what did they want us to do. The first request, and let me back up one more time, I'm sorry. That document also had in it citations from CMS and the Joint Commission that would essentially catalog and were footnoted to tell the reader why that particular language was in the document. So what I was initially asked was to take all of those footnoted documents and all the requirements and take them and put them in our existing bylaws so that we're compliant. In my opinion, I thought that was, one, since I'm not an attorney, I didn't feel comfortable with that. Two, I got two attorneys' opinions, including the attorney who recommended the initial document, and they said it would really be very costly and be very difficult to try and match up the language with the old language, with the understanding that the current document is not up to date. So my new proposal to the MEC was, would they be willing to take the document that was not approved, but that we know is compliant with CMS and Joint Commission, and try and identify what parts of that document that they were not happy with. And that might be an easier path to start with a document that's compliant, but let's remove the things that where people have difficulty. And they agreed to that at the last meeting. So that is the proposal. We added new members to the bylaws committee so that it is representative equally of Nashville general employed physicians, Meharry employed physicians, and the two medical staff leaders of the medical staff, the chair of the MEC, and the president of the medical staff. So that is the recommendation from the MEC, and we will proceed going forward with that starting May 1. Any questions? Okay. Should I go on with the?
Yes, go to the next one.
Okay. Very quickly, you have in front of you the credentials report. You see there's one physician, Dr. P.T. Wynn, who has been appointed for initial appointment. Again, to be cognizant of what you may not be aware of, according to our bylaws, you have a 2-year appointment, but your first year is provisional, which means basically that we watch you for a year, and if you do okay and we've monitored some of your charts, you will be advanced from provisional to full active. So that's what that means. So the following physicians have completed their provisional period and are being recommended to be promoted to full active staff, and they're there for your review. The following two physicians are being reappointed, and I see there's an error here in the document because Dr. P.T. Wynn appears under temps and initial, but he was initially under temporary privileges. Those were approved, so he actually is and should only be under the initial appointment category. And that leaves Dr. Inzarui, who is the only one for temporary privileges. And you can see Dr. Porter has submitted a resignation. For the SPP staff, same thing. You see those listed for initial appointment, those going from provisional to active, those who are being reappointed, those who have asked for a modification in their privileges. The nurse, Teresa Khan, is moving from, I believe, cardiology to urology, where she does have some experience in order to help us out in our urology clinic. And then you see the final two folks who were approved for temporary privileges. Let me pause there and see if there are any questions. Yes.
Just as a follow-up, and also on our action items, we had talked about potentially doing an exit interview for anybody who would be resigning, and I noticed that we do have somebody on this. So I would like to see, just as, trying to, again, establish best practices.
Let's note that, yep. And we'll get back to you on the next board meeting on the reason for resignation.
Thank you so much.
Thank you. The other thing I'm happy to mention is we approved the delineation for robotic privileges. We had our first 4 cases this week, which I heard were excellent, and we had a great outcome. And then we've got 4 other robotic privileges scheduled for next week. Also, for your information, you have a list of the policies that were essentially re-upped and any additions added, and including the nutritional care manual and the last 4 policies. And that concludes my report, Mr. Chairman.
Thank you, Dr. Williams. Any questions or comments? Yes, you recognize.
Sorry, just quickly, the robotics piece is very interesting. I know that's very exciting to have here. When do we think we'll be ready to start having some of those surgeries?
No, I'm sorry, that's what I meant. We had our first
we did?
surgeries, yes, this
Okay.
past week.
Gotcha.
And then we've got 4 more. So yeah, we're
4 more scheduled.
moving forward. And that was only 1 physician. We have 3 physicians who are in the queue to be trained, actually 4. Okay?
Thank you.
Were those gynecologic procedures?
Actually, general surgery.
Really? Okay.
And the others that are in the queue are, there is 1 obstetrician who has expressed interest who will get trained.
Okay. It says in here that the delineation of privileges is presented to the board for review and consideration. I don't know that we need to review it, but that's what it says, and we haven't had the
Yeah,
opportunity to.
we just want you to be aware
review it.
that we're not just doing procedures without privileges.
Yeah.
And actually, this is the first privilege in our core and special format where it literally lists what course procedures you need, or education and training, and what special that you need in order to do this particular privilege. So,
And I think just you learn a lot in reading the bylaws, and I'm just reading from medical staff committee. The medical staff committee will consist of at least 2 physician members of the board of trustees and additional members as determined. The committee will convene as needed to review practitioner credentialing applications and designate 1 physician member to review and provisionally approve credentialing applications.
where are you reading
we
that from?
doing
I'm sorry.
this? Is in the bylaws of the hospital authority board.
Oh.
So I don't think that we're. Is our credentialing committee doing that? Is somebody as a member of the board looking at applications?
I don't believe so.
So I think it's something that we need to address, either become compliant with that or change the bylaws if we don't think that that's necessary.
Dr. Williams, do you think we need a member from the board acting in that role? I mean,
You know, it's sort of like Dr. Hudson, if somebody has an interest in that and they'd like to be a part of that, that would be fine. I just think, asking board members to put more things on their schedule is a little burdensome. So it's up to, if somebody says, I love credentials and I just have, and there are people that have a hunger for that. So, I mean, I love credentials myself, but it's up to a board member to say, yeah, that's something I want to do.
I assumed this was done at some point when these were, but we've kind of gotten away from it. I mean, what I think is important is for the board to have some communication with the medical staff. And do we have a medical staff member here? And we would love to hear from them from whatever representative. But anyway, I guess the bylaws committee needs to deal with this and bring it to the board and see what we really want to do.
Yeah, again, if Dr. Burleson thought that was important to enhance their understanding of the report, that would be the first person I'd go to, unless someone else has an interest.
Okay, thank you.
For the sake of our minutes and to make sure we are approving what we need to be approving, you had suggested there was a name in 2 places, and I just wanted Janet to clean that up. Can you give me that again?
Yes, Dr. P.T. Wynn should be removed from the temporary privilege category on page 2, Janet. And will remain as full privilege on page 1.
Thank you.
Yeah, and I think this needs to be voted on, does it?
Any other questions or comments? All right, if not, I'll entertain a motion to approve. Been moved and proper second, ready for the question. All in favor, vote by the sign of aye. All opposed? Thank you, Dr. Williams. We now have our finance report. Bruce Nairmore and Ms. Smith, you all are recognized.
Thank you, Mr. Chairman. Just first of all, I think the agenda may have implied that David Hunt would be here with Crossland to review the audit. That has been deferred to May, just so everyone is aware. So that's the first. Second is for the budget update, just very briefly, we did present, as we told you at the last board meeting, we presented our budget request to Metro back in second week of March, I believe. We've not had any updates since then. However, we will update our year-to-date numbers for February, assuming they're approved here today, and then we'll look to see if there's anything that looks, with 8 months in, anything that looks like we need to adjust going forward. I haven't seen it yet, but that's a possibility. And then we do know, and I know our counsel from Metro said, the budget process at Metro with a new mayor and with some new staff in OMB and in Metro Finance, it's just a little bit slower or more deliberate than it has been in some prior years. And we're feeling the same, but we will meet any deadline. We're ready to go, and I think we'll have a good presentation. It looks like it'll be sometime in May, early May. Then the finance report, our February report. Mr. Chair, we had a small profit, about $330,000. We were slated to actually lose about $600,000. So all in, it's a favorable month for the hospital. Volumes were steady, not spectacular. I know we have some people in here from the hospital setting. We've done really, really well the first 8 months of this year with our length of stay management, utilization management, case management. And it's not just staff, that's physician cooperation too, the hospitalists and the specialists that cover. So when you look at our inpatient revenue on our income statement, our inpatient revenues are sort of down or flat this year, but the reason is our admissions are actually up 7%, but our length of stay is down about 15%. So my number of days Fanny's in the bed in the hospital are down, even though admissions are up. And if you're in the hospital business, that's a good thing, but it does impact my gross revenue. It probably reduces my costs, and since we get paid by admission, not typically by the day, that's actually a good thing for the hospital, and one of the reasons we're a little ahead for the year to date. But the areas that I would point out here, the clinic visits down on the left line, you see 3,979 clinic visits this month. We did acquire a practice over in Metro Center, very busy, senior-focused primary care practice over there. And they've been with us 3 weeks in February. And so my 3,200 rough clinic visits became 4,000, roughly 4,000, because those two gentlemen see a substantial number of patients. They deal with an older demographic, which is great for a hospital. I love to see 40-year-old patients too, but they don't visit the hospital very often. So it's nice to have a population there that probably will produce volume here in the hospital setting. And the trick is just to get those patients accustomed to coming here to have their imaging done and or have their minor surgical procedure done or their inpatient case done here. So I'll just say total revenue for the month was close. We missed on the inpatient line, but we did really well on the net patient revenue line, a little bit ahead of budget by $300,000 for the month. And then the other is our other revenue. We did get $13 million from the state supplemental pool this year. We were budgeting 10. So we've been amortizing that monthly through the 12 months. That's given us a lift all year. And then we also received a pretty substantial set of payments from state Medicaid MCOs that helped our other revenues by about $1.4 million this month. So those items were the ones that really made the month for us and made us end up making $300,000 because our expenses were relatively high for the month of February, but we had enough revenue to offset it. So a pretty good month, and if you just look at the year to date, we're about $4.5 million to the positive, $9 million ahead of budget and way ahead of last year. So it's good. It needs to stay that way or get better. Any questions?
I remember about 6 years ago, we had to go back to the city.
I remember that too.
And I'm only bringing that up to say what an amazing job with fiscal management from this team. And it's always good to have those type of reports. So, yeah.
Thank you. Yes, ma'am.
With the increase in the number of patients you're seeing in the clinic with the Metro Center, what's the plan to convince or get those same patients to come to this hospital if they get sick versus going to another hospital? Because it's one thing to see them in the clinic, because that's where they've been going, but it's another thing to get them to come to the hospital.
Well, I'm looking at you and Dr. Miller because you both are practicing physicians, and patients usually listen to their physicians for the most part, but they have to have a good experience if we try them here. I don't really have a role in that piece of it. I can't tell you how we encourage the two doctors over there to necessarily use us, but they are using us quite a bit for like physical therapy and other services that we have here. They're keeping Mark's therapist pretty busy here, and we're actually talking about moving some of, Dr. Webb wants to speak, but I think we're moving some therapy services over to that site for that very reason. And just, I tell you guys, and I warn everybody, if I can do it at a freestanding center therapy out there that's closer to your home, and maybe your cost share, if your patient is lesser, if you do it in that setting versus the hospital, we might get real busy over there and be less busy here, but that's a problem we'll deal with. But they have made us pretty busy in the therapy area already. Dr. Webb.
Well, the strategy for any system that places an outreach clinic is to encourage those individuals to refer those patients internally. That's just a natural process. The way we're going about doing that is making sure that they're being introduced to all of the specialty providers, that they're getting comfortable with them. Physicians take a lot of pride in referring their patients to someone that's going to take care of them. So it's not something you can just flip the switch on and say, you will send your patients. You really have to work with them to get them comfortable, and we're in the process of doing that with that group now.
More questions?
Any other questions? All right. Finance Chair, did you have anything to add? Okay. All right, I'll entertain a motion to approve. All right, it's been moved and properly second. Are you ready for the question? All in favor, vote by the sign of aye. All opposed, ayes have it. Thank you, Bruce.
Thank you.
All right, Dr. Webb, I think we are, yes.
All right. I want to, thank you, Mr. Chair. I want to take a couple minutes just to run through a few updates and announcements. On April 4th, we did celebrate our National Doctors Day here in all of our sites. Very good turnout on that. April 9th and 10th, our own Christian Clarkson, the director of CHIN, Congregational Health and Education Network, presented a poster presentation at Xavier University as a part of the Engaging Partners of Caring Communities, the EPIC grant, which is participated in by Tennessee State University, of course, CHIN, Meharry Medical College, and Vanderbilt University. On April 14th, we attended the SEIU Town Hall. And thank you, Dr. Martin, for being there and supporting the team. There was excellent participation as well and attendance by the Metro Council. And thank you to the SEIU for putting that together. It's good community engagement there. On April 18th, we had our we attended the American Heart Association Go Red Luncheon. As you know, our own Kaylin Harris was a woman of impact and did quite well with her competitive run. And is Kaylin here? Oh, there she is. Kaylin, congratulations. And she got edged out as far as the woman of impact, but actually Kaylin was representing the only woman of color out of the 9 participants. And for us, you're still a winner. So, thank you. On April 23rd, we hosted our 134th year anniversary for Nashville General Hospital. Very high energy activities on that day, and we're going to continue that celebration by hosting our 2nd annual community health brunch on the 27th. This year's theme is the heart of the community. We're excited to announce that the event is actually full, sold out, but if you're a board member and you want to attend, I know the owner, I think I can get you in. So please, if you're interested in attending, just let us know. And May 6th through 12th will be National Nurses Week, and May 12th through 18th. By the way, we will be putting a calendar of events out next week on both the National Hospital Week as well as National Nurses Week. On yesterday, a bill was passed in Congress that represented public hospital state employee incentive programs. It is a program that represents waiver of copays and deductibles for state employees that utilize the public hospital. The state employees must participate in the state group insurance plan in order to qualify. The bill was sponsored in the Senate by Senator Heidi Campbell and was sponsored in the House by Representative Jason Powell. We've worked with Representative Powell since January on this bill. It originated here, so the bill was passed with in addition to Representative Powell, Representative Jernigan, as well as Representative Harold Love participated in helping to get the bill passed. So that will mirror the Metro employees incentive program for seeking care at Nashville General Hospital and having their deductibles and copays waived. I want to give a shout out to the great work that was done by Community Health Marketing and the effort that was led by Jerry Maynard with his team. And the bill moves to the governor's desk for signature after the after the 2 approvals in the House and the Senate have already been completed, which is done. So the next move is to the governor's office and his desk for signature.
How will that affect us? We're already doing that, right?
No, we're not doing the state employees.
State
This
employees.
is new. I understand there are about 70,000 state employees in Middle Tennessee, 70,000. So it gives us an opportunity to an additional patient population, a commercial patient population. So kudos to the representatives that participated and Senator Campbell, as well as Community Health Marketing for helping us to move this through the House and the Senate. That concludes my report. Happy to answer any questions.
Does that apply to our outpatient clinics and hospital?
Yes.
So a state employee that would use our clinics would no longer have to fund the copay.
Yeah, just like the Metro employees.
Now we need to advertise that.
We will.
And I wonder if we can use that, it's a state law now to affect the people who do the billing, that we have trouble eliminating all that.
I was thinking about that. Maybe we do need to go back and revisit that with Metro as well. That would make it a lot easier. They would not receive the bill, which is confusing to them. I think we need to leave that on the table to address that.
Just tell them it's the law, now.
All right. Thank you.
Dr. Webb, this maybe just supports the whole notion that Dr. Miller raised about marketing, which I'm very interested in. We once talked very briefly, and I don't know if there's been any progress, but maybe we can get that crack political team to work with the, I guess it's the feds, because it's an interstate highway where we'd like to get an H that suggests that there's a hospital at this exit on the interstate for people to be able to come here if they need to. I hope we can figure out some way of getting them to figure out what it takes to get that H put up there. And even on some of the city streets, we could use some of that direction. There's plenty of direction that suggests that Meharry Medical School is here, but I don't see a lot that suggests that Nashville General Hospital is here. And I think we ought to be working on that.
We will certainly take that under advisement and pursue some answers to that. We'll get back to the board on what that's going to require.
One other thing to maybe consider is a urgent care clinic or walk-in clinic around the Capitol that would capture a lot of state employees.
All right. Good suggestion.
Kathy.
It's a long walk.
I'll be Dr. Fisher today.
We want to figure out where exactly those state employee offices are, where's the bulk of that 20,000, and then Metro provides us like a list of where all the employees, their addresses, so we can break it down by zip codes as well, and that will help drive some of the expansion into areas where we know we have a high concentration of employees. But yes, would love to get into a state building and put in like a dock in the box or something would be great.
I mean, if you were to offer something like that and some limited imaging services, et cetera, I'm not aware of any clinic like that downtown.
Right. So our Metro Center location is probably the closest one to the state capitol right now. So that's a big plus for us. We also have, Metro Water kind of in that back area of Germantown. But definitely as we're looking at expanding our footprint and hitting those high utilized areas, if you build it, they will come, right? Yeah.
So
I'm excited.
We'll be looking for those thank you letters coming from the other public hospitals in Tennessee. That concludes my report.
Thank you for your report. This is really good news. We want to celebrate those legislators who helped make this happen. So thank you for calling their names and for us getting this bill approved and opening the door of opportunity for the thousands.
Mr. Chairman, if we could get the names and the addresses, if somebody could send to us, I'd be happy to write a note.
Absolutely. Can we do that?
Ms. Cole said she'll have it for next month. They're coming to the meeting next month.
But I'd still like to get that within the next few days, so it lands on their desk. That's a very quick response.
Yeah. Thank you. Good work. That's really good news. And it was stated earlier that we do have to make sure if we have this opportunity that we make sure we have an effective marketing and make sure those state employees are aware of this opportunity as soon as it is assigned by the governor. So good work there. I just have one thing on my report, I guess, and that is that we talk with Mr. Lester. We want to kind of shore up how we are onboarding board members. We've got some that will be rolling off here soon and some new appointments in the next year or so. So I've asked him if he would lead that effort in getting with the executive team and coming up with a plan and sharing that with us at the next board meeting as it relates to our onboarding process for new members. If there's any other board members who are incredibly interested in that, you're welcome to join that team of one. If not, he will be working with the executive team to make it happen. So you do accept that, right, Mr. Lester? Thank you. All right. So at this time, according to TCA policy, we have on our agenda the opportunity to go into strategy session. In this session, we will not be voting on any business, and it will be strictly around the item listed. And so we do need a vote to go into our closed strategy session. So I'll entertain a motion at this time to recess into our strategy session.
Second.
All right. Do I need to do a roll call vote? Yeah. Ms. Lester, can you do a roll call vote, please? Aye. It's an aye.
Sorry. Dr. Fisher. Oh, he's almost here. Dr. Hudson. Mr. Lesser. Sorry. Dr. Martin. Dr. Miller.
Aye.
Ms. Smith. Aye. Mr. Stevenson.
Aye. Ayes have it. We will recess into our strategy session.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.